Welcome and thank you for joining us for the webinar, Strategies for Enhancing Well-Being and Preventing Burnout in the Transplant Workforce, presented by the AST Transplant Pharmacy, Psychosocial and Ethics, Trainee and Young Faculty, and Women's Health Communities of Practice. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. In a few moments, you'll see a viewership poll on your screen. We ask that you take this so we can understand how many people are viewing with us today. This webinar is being recorded and the recording will be available next week on the AST website and the COP hubs. Please note that your lines have all been muted so that only the presenters and panelists can be heard for the archived recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A window in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. Finally, at the conclusion of today's webinar, a short survey will appear on your screen. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Jennifer Byrns, to begin our presentation. Thank you so much.
Hello, everyone. Thank you so much for joining today. My name is Jennifer Byrns, and I'm a transplant pharmacist at Duke University Hospital. I practice in the outpatient setting covering abdominal transplant patients. And I'm very excited today to be a part of this webinar on strategies for enhancing well-being and preventing burnout in the transplant workforce. This webinar is a collaboration, as mentioned, between multiple COPs and available AST-wide. So I welcome everyone today. We have a wonderful group of speakers with expertise on our topic, and I wanted to welcome them as well today. So our first speaker is Stacy Fredrick. Dr. Fredrick received her Doctor of Pharmacy and Master of Business Administration degrees from the University of Buffalo School of Pharmacy and Pharmaceutical Sciences in 2018. She completed a PGY-1 acute care pharmacy residency and a PGY-2 solid organ transplant pharmacy residency at the University of Pittsburgh Medical Center, and she is a board-certified transplant pharmacist and a solid organ transplant clinical pharmacy specialist at the University of Rochester Medical Center, where she works with inpatient, kidney, pancreas, and liver transplant teams. Her areas of clinical interest include optimization of transplant patient education, opioid reduction, infectious diseases, and well-being. She's an adjunct faculty member of St. John Fisher University Wegmans School of Pharmacy and is a preceptor for 2 schools of pharmacy, PGY-1 acute care pharmacy residents, and PGY-2 infectious disease pharmacy residents. Our second speaker of the day will be Kelly Bryce. Dr. Bryce trained at the University of Detroit Mercy and completed her pre-doctoral internship at Henry Ford Health and postdoctoral fellowship at the John Dingell VA in Detroit. She joined Henry Ford Health as a senior staff psychologist with the Transplant Institute following training, and she is currently the section head of the health psychology for the system and lead transplant psychologist. In her clinical role, she facilitates psychosocial programming and conducts pre-surgical psychological evaluations for patients under consideration for both heart and lung transplant, as well as implantation of LVADs. In addition, she sees transplant and LVAD patients in both the in and outpatient setting for brief psychotherapeutic interventions aimed at improving coping, adjustment, and improving healed behavior. Her recent research interests include cognitive functioning and outcomes in transplant candidates, health literacy, and body image with LVADs. Our third speaker is Manpreet Samra. Dr. Samra is a mom of 2 littles, a transplant nephrologist by training, and she started a brand new kidney transplant program at the VA in 2020. She's an entrepreneur and is also a certified executive physician coach. She did her internal medicine residency at the University of Texas Medical Branch, a nephrology fellowship at the Kaiser Los Angeles Medical Center, and transplant fellowship at the University of Chicago. Dr. Samra is the current chair of the Trainee and Young Faculty Community of Practice, and her interests include transplant in the elderly, frailty, and telehealth as a way to bridge the gap. We have a few objectives that we'll be covering today, and I'd like to just run those quickly through with highlighting the prevalence and risk factors for burnout in the transplant profession, investigate the role of mindfulness in promoting professional well-being, and explore strategies to improve individual wellness to mitigate risk for burnout in the transplant workforce. And with that, I'll turn it over to our first speaker, Dr. Fredrick.
All right, thank you, Dr. Byrns, for the introduction, and thank you to the organizers for inviting me to speak today. My role within this webinar is to just introduce the concept of burnout within our profession and review some of the prevalence and risk factors. I have nothing to disclose. And I think it's important that we first introduce what is burnout. So the U.S. Department of Health and Human Services defines burnout as an occupational syndrome characterized by a high degree of emotional exhaustion and depersonalization or cynicism, and a low sense of personal accomplishment at work. The National Academy of Medicine found that symptoms of burnout were reported in 35 to 54% of physicians and nurses and 45 to 60% of medical students and residents. And this was in 2019, so these are pre-COVID numbers as well. Why do we care? Why is this important? 46% of all healthcare workers reported often feeling burned out in 2020, and that is up considerably from the 2018 number, which is 32%. And 44%, or nearly half of healthcare workers, intend to look for a new job in 2020, and that is also up from the 2018 number of 33%. So today, obviously, I will be focusing on burnout within the transplant population, and I'm going to be focusing on surgeons, nurses, surgery fellows, and pharmacists. Burnout is experienced across the board in many other disciplines. However, for the sake of time and in the interest for this webinar, I'll just be going over some information on these groups. I also just wanted to define how burnout is being assessed across these groups. There is a 22-item survey called the Maslach Burnout Inventory Human Services Survey for Medical Personnel, and henceforth I'm going to refer to this as the MBI because it's less of a mouthful than all of that. And this is a survey that has been validated in many different healthcare professions. And there are 3 domains within the survey: emotional exhaustion, in which a high score indicates burnout; depersonalization, again, a high score indicates burnout; and personal accomplishment. And for this domain, a low score indicates burnout. So first, looking at transplant surgeons, there was a national survey of American Society of Transplant surgeon members, or ASTS members, with 218 respondents that assessed burnout with the MBI and had additional survey questions surrounding frequency and comfort in dealing with emotional patient situations. And that was adapted from a survey within our oncology colleagues. And also some questions surrounding decisional authority, psychological job demand, and supervisor and coworker support, which was adapted from the subscales of job content questionnaire. Among the transplant surgeons who responded to this survey, 40% met the criteria for high emotional exhaustion, 17% for depersonalization, and then 46.5% for low personal accomplishment. The female gender was significantly associated with emotional exhaustion and depersonalization, but not sense of personal accomplishment. And age actually had an inverse relationship with emotional exhaustion and depersonalization, meaning younger respondents of the survey were more likely to report emotional exhaustion and depersonalization. In a hierarchical analysis, predictors of emotional exhaustion were found to be low decisional authority, high psychological job demands, and low coworker support. For depersonalization, predictors were low coworker support, greater discomfort in dealing with difficult patient interactions. And for personal accomplishment, the predictors were greater decisional authority, greater coworker support, and greater frequency and less discomfort in dealing with difficult patient interactions. And remember, for personal accomplishment, it's the inverse. So low personal accomplishment is indicative of burnout. The same survey was distributed amongst transplant nurses who are members of the International Transplant Nursing Society with 369 respondents. And this was the exact same survey as the one I just reviewed within transplant surgeons. Amongst transplant nurses, 51% met criteria for high emotional exhaustion, 16% for depersonalization, and 52% for low personal accomplishment. So these numbers are near or slightly higher than numbers that we're seeing in transplant surgeons. Males reported a higher degree of personal accomplishment than females, and amongst different nursing groups, organ procurement coordinators reported higher rates of personal accomplishment than most other nursing roles, and transplant staff nurses reported greater levels of personal accomplishment than pre- and post-transplant coordinators. Looking at predictors of burnout for emotional exhaustion, working more hours per week, having less decisional authority, greater psychological job demands, lower supervisor support, and greater frequency and discomfort with difficult patient interactions were all predictors of emotional exhaustion. Greater frequency and discomfort with difficult patient interactions was a predictor of depersonalization. And for personal accomplishment, older age, greater decisional authority, and lower discomfort with difficult patient interactions were predictor of higher personal accomplishment. Amongst abdominal transplant surgery fellows, a survey was distributed to all ASTS accredited abdominal transplant surgery fellowship programs with 77 respondents. Burnout was assessed again with the MBI, and this survey also included an 8-item grit scale and a 4-item subjective happiness scale. Interestingly, about 23% met criteria for burnout, which was lower than the numbers that we saw within transplant surgeons and transplant nurses. And lower grit scores and lower subjective happiness scale scores were seen in those with burnout versus those without burnout. Some additional predictors of burnout within the transplant surgery fellows, working over 100 hours per week, understandably, was seen more in the burnout group, as well as having severe work-related stress. And 94% of those with burnout had considered quitting fellowship compared to only 21% in the no burnout group. And probably most importantly for our patient quality and safety, 35% of those with burnout reported making a major medical error within the last 3 months, compared to only 5% of those in the no burnout group. And last but not least, for transplant pharmacists, a national survey of transplant pharmacists was sent out to the American College of Clinical Pharmacy, Immunology, and Transplant Practice and Research Network, as well as the American Society of Transplantation Transplant Pharmacy Community of Practice listservs, and 259 respondents responded to this survey. Again, burnout was assessed with the MBI, and 63% of survey respondents met criteria for burnout. In a multivariable analysis, risk factors for burnout included more than 10 hours per week of clinical duties outside of transplant and extreme fatigue. And importantly, 38% of those with burnout were likely or very likely to leave their current position for reasons other than retirement, compared to only about 11% of those without burnout. Subsequent to that survey, a secondary survey was sent out looking at workplace climate factors and their role in burnout. This was sent out to the same listservs as the previous survey with 135 respondents. Again, burnout was assessed using the MBI, and then there were 4 scales that were used to assess factors related to workplace climate. Those included the organizational constraint scale, qualitative workload inventory scale, and interpersonal conflict at work scale. This one was repeated 3 times for interactions with other clinical pharmacists, pharmacy management, and non-pharmacist members of the transplant team. And then lastly, the Utrecht work engagement scale. And I'll go over some of what these scales included in just a second. In this survey, 65.9% met criteria for burnout. Again, burnout was strongly associated with intent to leave the current position. And higher OCS scores, higher QWIS scores, and lower UWES scores were associated with burnout in the multivariable analysis. So what are all of these scales? There's a lot going on in this graph here, so I just kind of wanted to touch upon the key point. The organizational constraint scale asks respondents, how often do you find it difficult or impossible to do your job because of blank? And the answers: conflicting job demands, interruptions by other people, and inadequate help from others were the 3 questions with the highest percent of those with burnout responding several times per day. And of note, the responses to all questions were statistically different between those with burnout and those without burnout. On the quantitative workload inventory, the questions: how often is there a great deal to be done? How often does your job leave you with little time to get things done? And how often does your job require you to work very hard? Were the 3 questions with the highest number of those with burnout responding several times per day. And lastly, on the Utrecht work engagement scale, the questions: at my work, I feel bursting with energy. At my job, I feel strong and vigorous. And when I get up in the morning, I feel like going to work, were the 3 questions with the lowest percentage of those with burnout responding every day. And importantly, for the Utrecht work engagement scale, lower scores represent lower engagement with work. All right, so in summary, to bring this all together, burnout is very prevalent across multiple disciplines within the field of solid organ transplant. I really went down a rabbit hole looking into this. There's literature out there within transplant hepatologists, pediatric solid organ transplant teams, transplant coordinators, and the list goes on and on. So this is really a prevalent issue within our profession across multiple disciplines. And there are definitely some common trends in risk factors across all of these disciplines. So some of those common trends that came up multiple times were longer work hours, lack of support from coworkers and supervisors, work-related stress and demands, female gender, and younger age were all things that came up multiple times in these studies as predictors for burnout. And burnout is associated with likelihood of leaving a position, which is not good for our workforce, not good for our patients, and not good for ourselves. But there are things we can do about it. So I'm happy to pass it off to Dr. Kelly Bryce to take over for the next section of the webinar.
All right, thank you so much. I appreciate that. And let me pull my slides up here. All right, so yeah, that was a wonderful introduction into burnout and how it affects providers in the transplant space. So the next portion of this presentation is to focus on a tool or a strategy that we can use to combat some of that burnout that we all experience at some point. So the goal, I have no disclosures. The goal of this presentation today is to go over the definitions of mindfulness. We'll talk about the application of mindfulness into a medical setting. We'll explore the benefits of mindfulness and then go through a brief mindfulness exercise. So what is mindfulness? I think one of the most common definitions that comes out in the literature or when you're Googling or searching mindfulness is that from Jon Kabat-Zinn. And in 1979, John Kabat-Zinn was working as a microbiologist at the University of Massachusetts Medical School, and he started an 8-week program called Mindfulness Stress-Based Reduction. And he invited patients to take some time for self-care for themselves down in the basement of the hospital. And I think from here, things continue to grow and develop. So according to Kabat-Zinn, mindfulness is awareness that arises through paying attention on purpose in the present moment, non-judgmentally. It's a moment-to-moment, non-judgmental awareness to the present unfolding of experience. And often in the service of self-understanding and wisdom as a way of being more than doing and finding a deeper way to connect with yourself. Kabat-Zinn further suggested that we need to be optimally aware of who we are, where we are, and how we are in order to survive individually and as a member of the community. It is through mindfulness that we gain this awareness. When we discuss mindfulness, you'll often hear the phrase non-judgmental awareness or observing your thoughts without judgment. And I think it's helpful to explore this a little bit more of what this actually means. So non-judgmental doesn't mean that you won't have likes or dislikes or that you're completely neutral about things. What it means in the context of mindfulness is that we become aware of how judgmental we are and actually try not to judge that and to let it go, at least for a few moments. It means that we don't have to label things as good or bad in the moment, they just are. And by focusing of letting go of judgment, we can let go of our inner critic. Another helpful definition of mindfulness comes from Bishop and colleagues, which entails a and they talk about the self-regulation of attention. And this refers to observation, awareness of sensations, thoughts, and feelings moment to moment. This requires one to really anchor their attention onto what's happening in that moment, and then the ability to intentionally shift your attention from one experience to the next. The second aspect of their definition of mindfulness is orientation towards one experience. And this relates to the kind of attention that we hold to our experiences. The thought is that we have an attitude and a perspective of curiosity, openness, and acceptance. And by focusing our thoughts and attentions to the present, to be in the moment, allows the space for other things which cloud and clutter our thinking. Because spending too much time planning and problem solving, daydreaming, and negative thinking can be very draining. So mindful practice and mindfulness has its roots in Buddhist traditions, but this is something that is now well researched and supported as an evidence-based treatment that can be very beneficial. And mindfulness looks different, and a mindfulness practice can be different for anybody. And how someone may choose to practice varies, and there's a lot of strategies that one may use. So we can be mindful in different and very impactful ways. And when practicing these techniques and strategies, there's several things that we can focus on. For example, we can be mindful of our bodies. And this could include things like our breath, any contact, movement, or technical skills. There's mindfulness of sensations, be it unpleasant or pleasant sensations. We have mindfulness of our feelings and emotions, which could include happiness, sadness, anxiety, heaviness, and acceptance. And we have mindfulness of thoughts, which includes our attitudes and beliefs. And finally, mindfulness of mind, which might include things such as state of alertness, attentiveness, distractedness, holding on, or letting go, for example. Mindfulness practice can have both formal and informal practices. Formal practices might come to mind for most people, and this could include an intentional commitment of time. And this may range from as few as 1 or 2 minutes to 45 minutes plus of a practice. And these practices invite us to focus our awareness onto one thing. And this may be our breath, or an aspect of sensation, or stillness, or a focus on our whole body. And practicing formal mindfulness helps us bring mindfulness into our daily life. So examples of formal mindfulness activities include things like sitting meditation, awareness of breath, walking meditation, and eating meditation, sensory guided meditations, body scans, or even things like yoga. People might be less familiar with the idea of an informal mindfulness practice, and this can be thought of as more everyday mindfulness. In an informal practice, the goal is to notice or experience moment to moment and bring our attention to as many things as we can throughout the day. So a common example of an informal mindful practice is being mindful when you're washing the dishes. So paying attention to that sensation of the water running over your hands, noticing the dish, the shape, the size, watching the bubbles as they come over your hands or wash over the dishes, just paying attention to that experience. Another informal mindful practice might be sitting outside, listening to the birds, hearing frogs, or the rustling of the trees as you walk by. But both of these practices can bring benefit. So I want to shift next to talking about incorporating mindfulness into medical practice, or the work that we may be doing in the transplant space. So Dr. Ronald Epstein, there's two examples of his work here. The book he wrote called Attending Medicine, Mindfulness, and Humanity, and also a 1999 JAMA article published called Mindful Practice. I had the wonderful opportunity to attend a several-day workshop with Dr. Epstein that was supported by my Transplant Institute here at Henry Ford, and it was a really wonderful opportunity. And so I thought it would be beneficial to bring this into the webinar today. So Dr. Epstein is trained in family medicine and palliative care, and he has specific interests in communication and medical settings, and developed these innovative educational programs to promote mindfulness, communication, and self-awareness. And in his work and in these pieces, he discusses the benefits to healthcare providers when taking a mindful approach to patient care, and noting that this benefits both patients and providers alike. And as he stated here, mindful practitioners attend in a non-judgmental way to their own physical and mental processes during ordinary everyday tasks. This critical self-reflection enables physicians to listen attentively to patients' distress, recognize their own errors, refine their technical skills, make evidence-based decisions, and clarify their values so that they can act with compassion, technical competence, presence, and insight. And although he uses the term physician throughout his work, I think it applies to anybody working in the medical space. And Dr. Epstein really suggested that mindfulness is the link between relationship-centered care and evidence-based medicine, and should really be a part of clinical practice. So being mindful in your own practice and interactions with patients has several significant benefits. Dr. Epstein noted the goals of mindful practice are to become more aware of one's own mental processes, listen effectively, become flexible, recognize bias and judgments, and thereby act with principles and compassion. He further suggested the importance of remaining curious about the unknown and appreciating that we have an imperfect understanding of another's suffering. He stresses that mindfulness is the opposite of multitasking. And if any of you are like me, we think multitasking is what's going to get us through a very busy workday when we're getting pulled in multiple directions with emails and text messages and phone calls and looming IRB deadlines and so on and so forth, pulling us in different ways. The suggestion that Dr. Epstein makes is that we focus our attention in being very present in the moment that we are patient facing, or in any of the work that we're doing. So he has given the example in his work of taking a mindful moment before any patient encounter, and that's when he grabs the door handle to go into the room, and taking pause at that moment and letting go of the thoughts that are occupying his headspace at that time, and allowing his full attention and commitment to go into the patient encounter. So Dr. Epstein suggests several important characteristics of mindful practice, and this is what we can incorporate into the work that we do. So he suggests that we act with active observation of oneself, the patient, and the problem, that we keep peripheral vision, meaning we are aware of new information and perspectives, maintain pre-attentive processing, which is a subconscious accumulation of information from the environment. He always stresses being curious, noting that there's courage to see the world as it is rather than how we want it to be. A willingness to examine and set aside categories and prejudices, maintaining a beginner's mind, the humility to tolerate awareness of one's area of incompetence, the connection between the knower and the known. And further, he talks about being compassionate, being present, being attentive, and being self-aware. And all of these are strategies we can use to increase our mindfulness in the work that we do. This is a study which highlights the benefit of completing a mindful communication program or utilizing these strategies in the work that we do with patients. And the study found that there was sustained improvements in patient-centered attitudes, including empathy, psychosocial orientation, including physician well-being, with aspects of burnout and mood improving, personality, where there was increased emotional stability. The associations here were mediated by changes in mindfulness. And participants identified 3 common themes or improvements in following completion of this program, which includes a sense of community, skills development, and giving yourself permission to take time for self-development. Kang et al., this article is a bit old now, in 2011, has a great review though of the impact of mindfulness in using this as a strategy for self-care. So it's found that mindfulness is associated with higher levels of life satisfaction, agreeableness, conscientiousness, vitality, self-esteem, empathy, sense of autonomy, competence, optimism, and pleasant affect. It was found that mindfulness is negatively associated with depression, neuroticism, absent-mindedness, disassociation, rumination, cognitive reactivity, social anxieties, difficulty in emotional regulation, experience avoidance, alexithymia, and psychological symptoms in general. So we couldn't talk about mindfulness and not actually practice something today. So I invite you guys to go through this example with me if you would like to. If you don't, that's fine too, but just hang out and listen with me if you don't mind. And I'm just going, in the sake of time, make this a bit more abbreviated, but just wanted to provide everybody with at least an example. So what I'm going to go through today is called Leaves on a Stream. So if you could, as best as you can, sit comfortably in a position in your chair, wherever you may be, and you may close your eyes or rest them gently on a fixed spot in the room. And visualize yourself sitting beside a gently flowing stream with leaves floating along the surface of the water. For the next few moments, I want you to take each thought that enters your mind and place it on a leaf and let it float by. Do this with each thought, pleasurable, painful, or neutral. Even if you have a joyous or enthusiastic thought, place them on the leaf and let them float by. If your thoughts momentarily stop, continue to watch the stream. Sooner or later, your thoughts will start up again. Allow the stream to float at its own pace. Don't try to speed it up and rush your thoughts along. You're not trying to rush the leaves or the thoughts along or get rid of your thoughts. You're simply allowing them to come and go at their own pace. If your mind says, "This is dumb, I'm bored, I'm not doing it right," place those thoughts on leaves too and let them pass. If a leaf gets stuck, allow it to hang around until it's ready to float by. If a thought comes up again, watch it float by another time. If a difficult or painful feeling arises, simply acknowledge it. Say to yourself, I notice myself having a feeling of boredom, impatience, frustration. Place those on a leaf as well. From time to time, your thoughts may hook you and distract you from being fully present in the exercise. This is normal. As soon as you realize that you become sidetracked, gently bring your attention back to this visualization exercise. All right. Well, thank you for giving that a try and going through that with me. I have a slide here that says resources with no resources listed, simply because I didn't want to list any proprietary mindfulness resources. There's things that are out there. There's lots of apps. You can Google mindfulness. There's plenty of recordings that are available for free. There's scripts similar to this one that you can find available online. And it's something that you can certainly start to build into your own practice with as little as 1 minute a day. So thank you so much for your attention in this presentation today. And now I'm going to turn it over to Dr. Samra.
Thank you, Dr. Bryce. Can you see my slides?
We can't quite see them yet. Looks like you need to share your screen. I have them ready. I can pull them up and you can just tell me when to move them along.
That would be great.
Yeah. Getting them up. My computer is not.
Okay. Well, thank you to Dr. Bryce for laying such a great foundation and introducing mindfulness and that exercise. I don't know about everyone else, but as soon as you said, don't speed up the stream, my stream was going 2x. So it's really interesting, the importance of mindfulness. So I will be switching to the power of coaching and discussing evidence-based outcomes in combating burnout and improving patient care. Next slide, please. I am a certified coach. That would be my conflict disclosure. The outline of today's talk, we'll talk about what coaching is. We'll talk about the differentiation of coaching versus mentorship and coaching versus therapy, which is a question I get asked very often. We'll talk about the value of coaching and the evidence behind it. Believe it or not, there are randomized controlled trials that show the positive outcome of coaching. Next slide, please. So as Dr. Fredrick already has laid out, the foundation of what burnout is essentially emotional exhaustion with depersonalization and a perceived lack of accomplishment. Next slide, please. Physician-clinician distress initially can start off with one or two of these leads to burnout and can eventually lead to moral injury. Next slide, please. So what is coaching? Coaching is a modality that assumes that the person is whole, does not seek to diagnose or to pathologize. It's a way to maximally access personal strengths of an individual and skills, and it helps guide them to their own answers. It also restores a sense of agency within themselves, autonomy that a lot of times within large organizations we tend to lose, and self-efficacy versus the socialization of learned helplessness that can occur within the medical culture. Next slide, please. In coaching, we meet ourselves exactly where we are. We feel seen, heard, and validated. You identify common belief systems that you may have, and it's important to define a belief. A belief is a thought that we have again and again and again. A belief is not necessarily a fact, but it is the experience of life that we have had that leads us to have specific beliefs. And there are certain beliefs that serve us, but there are certain beliefs that do not. And a large part of coaching is identifying these beliefs and unlearning those that do not serve you. You find a heightened sense of self-awareness, especially of your thoughts and feelings, a lot of overlap between with mindfulness. You heighten the degree of self-compassion towards yourself and curate that curiosity. Coaching is also shown to reduce the vulnerability to burnout. Next slide, please. So coaching versus therapy, we know therapy relies on a medical model by specifically trained clinicians to diagnose and to treat. There are unintended consequences of therapy within the medical field. For one, there is stigma associated with it. There is fear surrounding medical licensure and certain questions that state medical licensures ask. Having a medical record that perhaps will give you a diagnosis. And as I mentioned, licensing concerns. There is a role for therapy, but therapy is not coaching and vice versa. Next slide, please. What is the difference between coaching and mentorship? So I'll start on the right with mentorship. This is a relationship in which one individual who's more knowledgeable and experienced guides a less knowledgeable and less experienced individual. We know that this is widely considered essential to career development, especially in academic institutions and within our transplant field. Both mentoring as well as peer support typically can involve physicians, clinicians, or other individuals that have direct experience in your field. Coaching, on the other hand, is distinct from mentorship in that it involves more inquiry, more self-inquiry, more encouragement, and external accountability, all towards the goal of increasing self-awareness, increasing motivation, and the capacity to take effective action from an empowered state. Next slide, please. So an overarching goal for the AST this year is to expand the transplant workforce. And in our webinar today, we also want to focus on the fact of how important it is to keep the transplant workforce we do have. Next slide, please. And this brings us into professional coaching as a tool and the evidence behind it. So I will go over two articles. The literature out there is so vast, I would not have enough time to cover all of it. This first one was published in August of 2019, titled Effective Professional Coaching Intervention on the Wellbeing and Distress of Physicians. As I said, this is a randomized clinical trial by Schanefeld et al. This was published in JAMA, and this occurred in the fall of 2017 to the spring of 2018. And this is a single institution, multi-site, randomized controlled trial. Next slide, please. They involve 1 hour of initial professional coaching session for each participating individual, followed by 5 30-minute sessions. And the frequency of these sessions was every 2 to 3 weeks, and this occurred within 5 months. This was an external physician coaching company that the Mayo Clinic, which is where this occurred, took place. So you can see that they randomized many individuals. You can see how many volunteered, how many did not, and ultimately they had 41 that were evaluable for primary analysis, which was burnout, in the intervention group, and 41 in the control group. Next slide, please. So this shows the baseline demographics. You can see that about half were women in the intervention group. The age most likely to participate was between 41 to 50. The majority were in a married relationship status. You can see the work location. So physicians were recruited from Rochester, Florida, Arizona, and other smaller sites within the Mayo Clinic system. There were family medicine physicians, internal medicine physicians, subspecialists, and on average, the number of years they were in practice was about 15 to 16 years. The number of hours worked per week was anywhere between 54 to 57, and you can see how many were involved in direct patient care versus administrative roles and education roles. Next slide, please. So what were the themes that were discussed during these coaching sessions? A very common theme was optimizing the meaning in work. If you look at, our trajectories in our trainings, we all have a very direct path. We go from our professional school, perhaps to a residency, perhaps to a fellowship, and then we start our attending jobs, and we have this direct career trajectory. And we have this arrival fallacy that when we arrive at this, then things will be better. And, you can insert whatever you'd like into that. And then there comes a time where you ask yourself, well, is the work I'm doing value aligned? And that's really what the discussions around optimizing meaning in work were. Integrating personal and professional life, recognizing that we are one whole human being and that we are not just our professions. And so sharing tasks with your partner at home, meeting needs of aging parents. A lot of us are within the sandwich generation, and reducing work-home conflicts. Building social support and community at work. Another role for having that peer support. Improving work efficiency, learning how to be efficient with email, or doing additional EMR training to be efficient with your charting. Addressing workload, prioritizing and saying no. This is something that we were discussing prior to the start of the webinar, is creating healthy boundaries, avoiding overscheduling. A lot of times we get so excited to work on a project, not realizing that we already have a full schedule. And so the time that we give ends up being, the time at home, the time where we could be practicing mindfulness. Building leadership skills, pursuing hobbies and recreation. A lot of times within the transplant world, our cortisol levels are just at such a high baseline because of the work that we do. We deal with life, we deal with death, we deal with rejection. And so it's really important to curate hobbies and recreation where we have periods where that cortisol actually goes down. Engaging in self-care exercises, exercising, eating a balanced diet, making sure we attend to our own medical needs. So if you haven't seen your primary care physician in over a year, please make that appointment. And then strengthening your relationships outside of work, scheduling social events with friends, and showing appreciation towards others, and practicing gratitude. Next slide, please. So this, for the sake of time, we'll move this slightly quickly. So this is just the baseline well-being, job satisfaction, engagement, and meeting at work of all the participants. Next slide, please. And this is what I want to highlight, is that the changes from baseline 5 months after being randomized, and you will see that the emotional exhaustion, the absolute change, and the relative change was much higher in the intervention group. The same goes for the overall burnout scores, and the overall quality of life improved significantly when you compare it to the control groups. Next slide, please. So in summarizing this study, professional coaching is an evidence-based intervention for clinician well-being, resulting in improved emotional exhaustion, burnout, resilience, and quality of life. Next slide, please. So the second study that I'm going to focus on is slightly different, because this was not done within an organization. This is actually an analysis that was done for women physicians using the RE-AIM framework. And this is very interesting because of the 201 participants that actually filled out these pre and post surveys, I was one of them. And so they have their exclusion criteria listed here. They have their primary outcome, which was a large effect size on professional fulfillment and burnout, and self-valuation, which is a measure for self-compassion. These were virtually held. The delivery and adaptation was all done via Zoom. The cost was anywhere between $5,000 to $10,000 per participant. They were self-selected, so it's very important to know that as well. And in terms of long-term attrition, there was no significant attrition during this 8-week intervention. And some continued the program for beyond 6 months to 2 years. And many, including myself, actually trained to become physician coaches themselves, further contributing to this broader reach and implementation. Next slide, please. So as you can see, I mean, the results were quite profound. What this program consisted of was 24 large groups during large group coaching during the 8 weeks. So there were 3 per week. There were 6 small groups held every Saturday, and then there were 8 one-on-one individual coaching sessions done as well. And as you can see, in the first baseline, you can see how improved the professional fulfillment was. At the beginning, 27.4%, 68.2% at the end of the 8 weeks. You can see the means on the right side. Burnout improved from 77% to 33.3%, and self-compassion went up from 17.9% to 63.7%. So very profound effects. Next slide, please. And then there's a business case for this. The cost of physician burnout is $4.6 billion, and this comes in the form of reduced clinical hours and turnover. One lost physician and even clinician can result in a loss to the system, to the institution, to the organization of $500,000 to $1 million per clinician. There are some programs that offer CME, but at the end of the day, it's very important to know that coaching and burnout can be improved. The investment is justified, and the return on investment is clearly measurable. Next slide, please. So to summarize, professional coaching can be tailored to focus on the individual aspects desired to help navigate your professional life, your choices, and the direction of your career. Coaching, mentorship, and peer support are distinct from therapy, which is conducted by individuals trained to work with mental illness and conceptually relies on a medical model to diagnose and treat. External professional coaching can complement mentorship. Professional coaching differs from other commonly described offerings, such as mindfulness, nutrition, exercise, and support groups. Coaching helps to build a capacity to influence organizational systems that affect their well-being, and hence expand the framework of the types of offering that organizations can provide both personally and professionally. Next slide, please. So these are just a handful of the resources and references. Next slide, please. And thank you so much. We will now open it up to the question and answers.
All right, thank you so much to all our panelists. I'll welcome you back here. And I thought this was a wonderful presentation, and I loved the ability to be able to actively practice mindfulness, because it is very difficult to quiet the mind, to be present in the moment. And it's very nice to have an activity that helps you kind of come to the center and understand where you are and push off thoughts that may be intrusive and other things happening. So thank you for that. And I will welcome any questions that the audience members may have. You can place those in the Q&A section of this Zoom webinar. I had a question myself. I wanted, as a person who's involved in helping with mentorship of learners, when and how do we start these conversations on incorporating mindfulness and helping and developing coaching mechanisms for our learners as they are entering into practice, and meet them where they are, and also assess how they're doing and what their well-being is?
I'm happy to start with that. I think it's important to start right away. I think very early in the process, it's part of our job, I think, to set our learners up for success and teaching them these strategies and techniques they can use to be successful going forward.
Yeah, and I'll just echo what Dr. Bryce said. I can tell you when I was at UIC, the medical school I was involved there with had a whole wellness branch, and they discussed these mindfulness and stress-based reduction exercises. This was a part of their curriculum, so I think it really should be a part of the curriculum for professional schools.
I also agree. I don't think there's any time that is too soon to start incorporating some of these things. I think that especially during school and residency and any type of training, those are known to be stressful times. So I think having a preceptor to acknowledge that and to say, you know, I understand that this is stressful. I really want to make sure that your well-being is being prioritized. Here are some things that you can do, either referral to your institution's mindfulness program, taking a mental health day, you know, allowing them that option if it's really needed. Things like that. I think it's important that they see that their preceptors are valuing mindfulness and well-being from the beginning.
Thank you, guys. What about as a person who likes to be involved in a lot of different things and trying to not overfill the plate? How do you advise practitioners to politely say no when they don't have the bandwidth to be able to create a work-life balance that's sustainable?
I just had to do this so I can chime in. I have a 4-month-old son. He's very handsome. If anybody ever wants to see pictures, I'm happy to send them. But at the beginning of this year, he was born in June. So at the beginning of this year, there were a couple of things that people reached out to me and, you know, asked me to take on, you know, either a committee role or, you know, a research project or things like that. And just, they were all things that I was really interested in and that I thought, you know, would be good for my career and good for networking and good for, you know, our profession as a whole. But ultimately, even though I wanted to say yes, I knew that I would not be good at doing those things right now. So it's, you know, not only prioritizing my own work-life balance, but also prioritizing those things that I said no to by just recognizing that I'm not going to be able to put everything into this right now. And I'm not the right person for this job right now. So I guess just prioritizing those things by not prioritizing those things.
I'll share a skill that's been very helpful to me is you list out all of your priorities and then you do a time audit and you see where your time is going and you see if those priorities and where you spend your time is aligned. And when it's not, you start recognizing what you need to say no to. And definitely, just like Dr. Fredrick said, saying it with gratitude. Thank you so much for thinking of me, but at this point, I'm not able to give this time commitment.
Well, thank you all. And I think that actually now takes us to 4 o'clock. So thank you to all of our panelists. Thank you to all of our attendees. And thank you to AST for allowing us this opportunity to be able to share expertise and knowledge on a very timely topic that we can all use in our practice.
Yeah, and thank you on behalf of AST for such a great presentation. And we'd like to thank all the attendees as well. Just a reminder to please complete the evaluation survey that will come up on your screen after the conclusion of this webinar, and the recording will be available next week. Thank you so much.